Yes, thank you. My name is Anna. I'm a PhD fellow at the Department of Biomedical Science. And I'm going to do something wild here. I'm going to change the organ to the kidney. And I'm going to talk a little bit about the renal effect of glucagon in relation to diabetic kidney disease. But yeah, since I am changing the organ, I thought that I might dig into some background first. So the kidney consists of approximately 1 million nephrons. And of these, each of these nephrons consists of a glomerulus. And they have a lot of important cells, especially the mesangial cells, which are very important for basement membrane remodeling and also response to local injury. And they're very important for glomerular filtration control. And besides these mesangial cells, we also have the podocytes, which are very important for glomerular filtration control, but also for structure and function of the glomerulus. If these cells somehow gets damaged or loses their ability to function properly, it can lead to chronic kidney disease. So chronic kidney disease is defined as a progressive worsening of renal function over time that eventually ends up in complete renal failure. And it also increases the risk of other diseases such as cardiovascular diseases, and it can lead to premature death. There are many different disease markers of diabetic kidney disease. Some of them very important ones are increased urine albumin and also a misbalance in electrolytes in the urine. And abnormalities detected by histology, such as damaged glomerulus, scarring, or damaged tubules. And of course, decreased GFR. There are different causes of chronic kidney disease, but the two of the main ones are hypertension and diabetes, where diabetes is by far worse the leading cause, where 1 out of 3 adults with diabetes develop diabetic kidney disease. And a common factor for these individuals with type 2 diabetes is that they have increased plasma glucagon levels. And glucagon has previously been suspected to have an effect on the kidney function. Already back in 1977, it was shown in healthy males that when given a glucagon infusion, it increased the glomerular filtration rate and protein excretion. And also in animals, it was shown that when giving a glucagon infusion, it created misbalance in electrolyte excretion. And patients with end-stage renal disease have elevated plasma levels of glucagon, all suggesting a role of glucagon on renal function. So we have previously located the glucagon receptors in the glucagon receptor in the kidney using different approaches. One of them being immunohistochemical staining of the mouse kidney, where the glucagon receptor was significantly located in the distal tubules, and also by autoradiography, where it was mostly located in the distal and collecting duct cells. Again, supporting a possible role of glucagon on renal function. So, could this increased level of plasma glucagon seen in type 2 diabetes in fact be a contributing factor in the development of diabetic kidney disease? To test this hypothesis, we set up a chronic study to investigate chronic activation or inhibition of the glucagon receptor. In a period of 8 weeks, we treated healthy female black 6 mice with either a glucagon analog or a glucagon receptor antibody blocking the glucagon receptor. And we wanted to look into different markers of diabetic kidney disease, such as urinary albuminuria, histopathological changes within the glomerulus, and transcriptional changes within the kidney tissue. So in order to assess the effect of glucagon on glomerular function, we measured the kidney weight and albuminuria. And we found after 8 weeks that the mice treated with the glucagon analog had a significant increase in albuminuria, suggesting a loss of filtration surface area in these mice. We did not see any change in kidney weight in the analog-treated mice. We did, however, see an increase in the kidney weight in the glucagon receptor antibody-treated mice. Glomerular function was also assessed by histomorphological measurements of mesangial cell area. Here we found that significant mesangial matrix expansion in the glucagon analog-treated mice were significantly increased. Suggesting a loss of filtration surface area. This mesangial area expansion might be a direct effect of glucagon, since a decrease in mesangial cell area was measured in the mice having the glucagon receptor blocked. And then we also assessed a histomorphological measurement of the parietal layer of the Bomholt capsule. And here we found that the glucagon analog-treated mice had a significant increase in the thickening of the capsule. And this might be due to increased pressure or even podocyte loss, which causes parietal cell differentiation and then causing a thickening of the capsule. And no changes was observed when blocking the receptor. So to examine transcriptional level changes in the kidney tissue and to look further into the molecular mechanism underlying the observed effect of especially increased albuminuria, but also the histomorphological changes, we performed RNA sequencing of the whole kidney tissues. And of relevant changes, we found significant changes in the fatty acid metabolism, in podocyte regulation, but also in sodium transport regulators. The downregulation of fatty acid metabolism genes reduces mitochondrial fatty acid beta oxidation and causes lipid accumulation and renal lipotoxicity, and also tubular injury, and will result in ATP depletion. And previously, renal lipotoxicity and accumulation has been linked to cause mesangial expansion, but also podocyte detachment and death, leading to albuminuria. We also observed increased transcription of mTOR and decreased transcription of this PT-Pro, which is glomerular epithelial protein 1 that is present mostly on podocyte processes in healthy glomerulus. And it has been associated with the podocyte injury. And also the mTOR, when hyperactivated, it causes podocyte injury and loss. We also looked into potential changes in renal electrolyte. And here we saw that sodium reabsorption in the kidney, which is driven by these sodium-potassium ATPases, were mostly downregulated. The alpha subunits were downregulated, whereas the beta subunits were upregulated. And it has previously been demonstrated that these ATPases, they also are involved in causing a kidney injury. So to summarize some of my findings, the increased, when the mice received the glucagon analog, they had an increase in albuminuria. And they also have an increase in mesangial area expansion, whereas the opposite was observed in the mice having the receptor blocked. And we also observed the Bomholt capsule thickening in the mice receiving the analog. And of transcriptional changes, the glucagon analog-treated mice showed transcriptional changes in the gene related to fatty acid metabolism, podocyte regulation, and sodium transport regulation. So to conclude on this, we saw that increased plasma glucagon is a significant contributor to the development of different diabetic kidney disease markers such as Bowman capsule thickening, mesenteric matrix expansion, formation of albuminuria, and podocyte loss. Thank you.
Thank you so much. Any questions?
Thank you for an interesting talk. I was just I was just speculating whether you could comment on, do you believe that these effects are directly mediated by glucagon acting in the kidney, or potentially an increase in the blood glucose, which you potentially see by glucagon treatment?
Yeah, that's really hard to tell at this point. We really need to do some more experiments, but of some of this effect we see when we block the glucagon receptor, we see either the opposite effect or no effect at all, but it is hard to conclude on that at the moment. Yeah.
I apologize if I missed this, but how long did you treat your animals in this study?
8 weeks.
So it should be noted that with the dual and triple glucagon agonists under development, where they've done mice for 6 months, in cynomolgus monkeys for 9 months, and these are GLP toxicology studies, they haven't seen any renal effects.
Okay. Thank you.